Thank you to all the speakers, and I invite you to Drs. Ogden and Bullock to come up to the panel, and we will be a little bit shorter of our 15-minute discussion time, but we're going to still make that up. You won't shorten this much, which comes after this. Okay, so well, I'll say again, just thank you to everyone. This is, I think, exactly what we needed to show the diversity of issues, the extent of the problem, and so forth. If I hold this up, new type of mic, right? Okay. And I'm wondering, just to start off with a question, a quick question, and then we'll go to the audience. You presented a lot of data to help describe the problem and some of the reasons why. The question is, what data would be your dream data to help us figure out the solutions, especially those that are related to social determinants? Don't follow my example, right? Okay.
Data would be data that follows a uniform protocol. Our response to the ADA was a practical solution where we had 4 cohorts, which were the only clinical cohorts of Asian Americans in the United States, but we all had different protocols. So Dream Data would also include information about immigration status, for example, as well as the social determinants data that you have. I think there are a lot of stressors in undocumented immigrants, and that's not captured in any of our current surveillance tools.
I would add dream data. Actually, this is probably more almost hallucination level dream, but would be to have data that looks at truly the life course. So looking at risk factors in parents, epigenetic marks, in utero exposures, and we need to, of course, include not only the exposures of stress and poverty and trauma, but also the environmental exposures related to pollution and contaminants that predominate in low-income communities. Moving on through birth weight, childhood experiences, childhood growth curves, food insecurity, you're getting the picture on and on. So we can really see the true, more total picture across the life course and how each of these things contribute to different levels of risk for children and therefore adults.
I would echo this. If we had longitudinal data, that would be great. I'd love bigger sample sizes for Haynes because there are data about U.S. born versus not. And there is information, but we don't have the sample size to look at the granularity because there's such heterogeneity in the population. So,
thank you. First question, Bill Dietz. Yeah.
Bill Dietz, roundtable member. Thank you for these presentations. And given what you describe in terms of the poverty, food insecurity, and adverse childhood experiences, a decline in rates of obesity and complications is the last thing that I would expect. So what's going on to account for those declines?
So obesity, and nice to see you again, Bill, but obesity is level. It's not, at least in children. We don't have good data on adults, or at least we haven't been able to analyze it yet. So what do we think is going on? This is now also in the dream realm of things, I guess, because all I can do is speculate. We don't know. Has there been enough improvement in socioeconomic status in enough communities that we're seeing overall trends being different because we haven't been able to drill down to community level? We know there's huge differences in diabetes prevalence, for example, across the different IHS regions across the country. So it's not a uniform thing. In fact, the rate of diabetes in Alaska natives is lower than it is in white Americans, whereas it's way higher, significantly higher. Some of the highest rates in the world are in the people around the Phoenix, Arizona area. So there's a great difference across. And is there enough change in socioeconomic status that we've been able to show perhaps some change in the overall pattern? I don't know. while the STPI is not the whole thing that we can give credit to, I think it's a model for being able to have people, communities have dollars which are given to them in a grant way, so that they have to apply to do it, but they get to do a wide variety of projects. That self-determination, it's not only the project itself, but it's that ability to determine what you want to work on. So it's probably a very complicated answer. I think some of it is simply resilience in the face of ongoing adversity. There's a lot of sense of community in Native American communities that does not necessarily exist in many other parts of this country. And that, of course, is a protective factor. That sense of interdependence and the value that the community is higher than your own value. I mean, that's secondary value. It's not an American value, but Native Americans still believe that taking care of family and community is higher. So I think we're seeing some protective factors, some resilience factors, and perhaps some improvement in at least some aspects of socioeconomic status in enough places. That's my best guess, but we don't have data to back up anything I just said.
That would suggest that we ought to be measuring social capital in these communities and a longitudinal.
Capital, of course, in other communities has been shown to be strongly associated with health outcomes in children and adults. So absolutely social capital. Thank you.
I have another question. I don't see anyone else at the mic, but I just wanted to follow up on the issue of American Indians in urban communities, because one of the aspects that's so obvious with the Indian Health Service is that people have universal access if they qualify. And I'm wondering, I've heard colleagues say that if I were to have data for urban American Indians, it might look a lot more like the urban black population than an American Indian. I just wonder if you have any data on that or could comment on that.
So, right. So importantly, we do have, if you qualify for care, you can access it regardless of ability to pay. In fact, we cannot charge a Native American person for their health care in the Indian health system. So, plug for universal health care. So yeah, it's a huge factor in it. Urban Native Americans are a large proportion, actually, of Native American people. We think only of Native Americans on reservations, and still, many of our people do live on reservations, but actually more live off reservation than live on. And while there are urban Indian organization clinics, and there are also some Indian Health Service and tribal clinics in urban areas, separately, confusingly but separately, we know that most Native American people who live in urban areas are not accessing care consistently from one of those places. There's simply not enough of them in enough places. So we have some data on urban Native Americans, but it's incomplete for sure, and tends to be not broken out in whatever healthcare system they may be accessing as opposed to ours. So it's something that's very much needs better data for. I'll add that to our list.
So that's another mandate for the Haynes to get larger sample sizes for some of these populations. I know that's not possible. Okay, well, since I don't see any other questions, and we were to have our break at 10 a.m., we're going to adjourn now. But we will have ample time for questions in the next session, which will be about more context and so forth. So I think we will move on, and then save your questions, write them down, because once we have the speakers in the next session, after the break, we will have a little bit longer Q&A. So thanks again, another standing ovation, and I'll ask Jim Salas to come up.